Good evening. I welcome all of you for FOGSI ICOG Hormony web series on endocrinology in women. It's in association with the Endocrinology Committee of FOGSI. So this is the very first episode of this web series. At the outset, I'd like to ask Dr. Chaitanya Ganpule, who is the convener of this web series, as well as the chairperson of the FOGSI Endocrinology Committee, to address us all.
Good afternoon, all. Thank you, Manasi. Along with my co-convener, Dr. Vaishali Korde Nayak, I would like to welcome all of you for this very first episode of the web series called as Hormony. It's an ICOG web series along with the Endocrinology Committee of FOGSI. Now, the concept of this hormone series goes back or dates back to, our residency days when most of us used to put all the endocrinology subjects for, if something comes. So we were not very keen, or we never went through the spear off and everything to the extent that we should have gone. And then when we went back into the practice, all that we see is endocrinology. From day one, you name the topic or you name the clinical situation which we come across in our practice, it's endocrinology. So this concept of having the web series was to, have that endocrinology as a topic and to develop interest of these postgraduate students in the subject of endocrinology as such. With this, we have started this web series specifically designed for the postgraduate students, for both as I said, to having interest in that particular subject, and from the examination perspective as well. So we are going to have this every month, every third Wednesday of the month, and we are going to have it in a certain way. So now I would like Dr. Sarita Bhalerao, who is the secretary of ICOG, to say a few words before we actually start with the talks. Over to you, Dr. Sarita.
Thank you very much, Dr. Chaitanya, and it gives us great pleasure on behalf of ICOG to collaborate with the Endocrinology Committee of FOGSI for this new web series on Hormony. As you said, endocrinology is very, very important, and I'm sure that this web series will do a lot in clearing concepts and also bringing out all the recent updates that have happened in this field. So I congratulate Dr. Chaitanya Ganpule, who's the dynamic chairperson of the Endocrinology Committee of FOGSI, and Dr. Vaishali Korde Nayak, who's a very well-known academician and professor at Maimar Talegaon. And I welcome Dr. Shilpa Shirsagar, our speaker, and Dr. Meeta Gupta. They are our speakers. Dr. Shaili, our chairpersons, and Dr. Hebziba, who's an old friend from the Menopause Committee, IMS. She's from Chennai. And I'm happy to see all our those who are conveners, who are going to coordinators, who are going to coordinate this series. And I'm sure this series is going to be very, very exciting. So without further ado, let's go ahead.
Thank you, Dr. Sarita. I would like to say a couple of words for the coordinators, Dr. Manasi Naralkar, Dr. Madhu Juneja, Dr. Manasi Sharma, and Dr. Vinutha from Bangalore. All four of them are going to be the coordinators for this entire series. Today, we have Dr. Manasi and Dr. Vinutha joining us. In the episodes to come, the other two coordinators would be joining as well. Over to you, Manasi, for the introduction of the chairpersons and the start of the first talk.
Thank you, sir. It is my great pleasure to introduce Dr. Professor N. Hebziba Kirubamani. She was a former superintendent of government RSRM hospital and a visiting professor of medical college and CSI Specialty Hospital. Was the past president of OBGY Society of South India, past president of Chennai Menopause Society, past IMS chairperson for Education Committee, joint treasurer of IMS in 2024 and 25, and she received 2 consecutive years the Best Society Award during her CMS president tenure in 2022 and 23. She is,
Yes,
she
ma'am.
has many awards
Go
to
ahead
her.
to the next chairperson.
Oh, we welcome you, madam. I would also like to welcome Dr. Shaili Agarwal. She is a professor OBGYN in GSVM Medical College of Kanpur and also the secretary of the Kanpur Menopause Society, the scientific secretary of the Kanpur OBGY Society in 2023 to 25. She has a lot of awards to her credit as well. The Great Teacher Award in 2021 as well as the KOGS Icon Award in 2024. We welcome you, madam. We would also like to invite now our first speaker, Dr. Shilpa Kshirsagar. She is the a consultant gynecologist in IBCLC, and she has multiple awards and publications to her credit. I hand over to Dr. Shilpa Kshirsagar to deliver her talk. Her topic is physiology of menstruation.
So this
Thank you so
we
much.
have started with the basics. So we have got two topics today, physiology of menstruation, and then from that comes out the physiology of ovulation.
Yes. So thank you very much. I'm just sharing my screen. Just a minute.
Till Shilpa is sharing her screen, we would just like to welcome her. She's a thorough academician and professor at D.Y. Patil Medical College, and she loves to teach, and she is the opening for this series. So Shilpa, we are expecting a century, so just go for it.
Thank you, ma'am. Thank you so much. Actually, to speak in front of so many stalwarts itself is a great honor, and I am really thankful to FOGSI and ICOG Endocrine Committee for giving this opportunity. Is my screen visible, ma'am?
It's visible. Make it
Yeah.
full
Thank you.
screen. Make
Yeah,
it
yeah, I will. I will do it. Okay. So thank you very much. And we start with the physiology of menstruation. So first of all, as sir said, it is mainly basically intended for the postgraduate. So first of all, welcome to the all postgraduates to the gynecologist convention, and henceforth maybe for next 50 years you are going to practice the gynecology. So it is very important, as sir said, that every patient is directly or indirectly related to endocrinology, and it is very apt to have the first lecture as physiology of menstruation. So I would first like to share one incidence. One day when I was sitting in the OPD, one resident asked me, ma'am, for some patient of the same menorrhagia, you are giving progesterone, for some you are giving only the tranexamic acid and mefenamic acid, for some you are giving OC pills. सिमिलर इज फॉर डिस्मेनोरिया. अगर डिस्मेनोरिया के साथ कोई पेशेंट आती है तो किसी को बोलते हो इट इज़ नॉर्मल जस्ट गिविंग मेफेनामिक एसिड, और किसी को तो सोनोग्राफी लिख के देते हो. सो व्हाई इज इट सो? सो these kind of questions will be coming to your mind unless if you are not thorough with your physiology. So every answer lies in the physiology of menstruation. There are so many topics which you will be able to better understand if you understand the physiology. Otherwise whole of the life you will face the same, क्या करे क्या ना करे, ये कैसी मुश्किल है. So basically, as I described, why to study physiology as a part of basic sciences, which we have almost done in the MBBS curriculum. To know the abnormal, you need to know what is normal. So if a patient is complaining of I am having a cycle of 30 days or 32 days, you might label her as abnormal if you don't know that the normal duration of cycle is 21 to 35 days. So similarly, the normal flow of the bleeding is around 4 to 5 days, and the various terminology related to it like menorrhagia, dysmenorrhea, menometrorrhagia. Because you being PG students, I hope you are already aware of these terminologies, and we will not be wasting much time on these terminologies. The 2 points I have highlighted here is about to understand its application in clinical scenario and to pass in exams. I think to pass in exams is right now your primary aim, but at the same time, to understand its application in clinical scenario is equally important to practice you further. So today, when I was asked to deliver this lecture, and I again went to the Spiroff. Of course, everybody knows Spiroff is whatever you say, Bhagavad Gita, Bible, whatever you want to say for the endocrinology related to obstetrics and gynecology. But sometimes it happens that you are not able to recollect those points from Spiroff, and each and every one of you must read Spiroff. There is no option for it. And with due respect to the book Spiroff, because we have been reading since 30 years, I thought I would present to you the points from Spiroff. The whole of the presentation, the reference is Spiroff. But I would present it to you in my way, in Shilpa's style, and so that you can apply these points and you can actually understand why this is happening. So, is my screen visible to you all? Can you see the QR code? Those PGs who are present here can just scan the QR code and answer the question, why menstruation occurs. I'm not asking you for the menstrual cycle. I'm just asking about the menstruation. Is the QR code getting scanned? If there are any technical errors, any difficulties, we can just keep that. Manasi, can you just check? Okay. Shading of endometrium, I got my first answer, yes.
Yes, we are able to scan it.
Okay, okay. If you are not able to scan, you can write the answers in chat box as well. Okay, we will go ahead. So basically the menstruation occurs to get ready for the next cycle of implantation. And the response to cyclical changes in hormones, and it is a response, the menstruation itself is a response to cyclical changes in hormones. And these hormones are nothing but the result of hypothalamo-pituitary ovarian axis. So as you all know, the puberty and the menopause, where the HPO before puberty and after menopause, the HPO axis is not active. So if you can note, okay, so the orderly cyclic hormone production and parallel proliferation of uterine lining for implantation of embryo is the main purpose of whole of the menstrual cycle. So the menstrual cycle itself consists of the ovarian cycle as well as the uterine cycle, and the purpose is to welcome the baby are required or the embryo are required. Those preparations are nothing but the normal menstrual cycle, and in case if the baby or the embryo does not arrive, if there is no pregnancy, those changes will be shed off, and that is the simplest answer why there is a menstrual cycle. So the menstrual cycle being of 28 days and the time assigned to me is less than 28 minutes. So of course I may not be able to teach you or cover each and every point, but definitely I guarantee you that you will go home with a lot of take home messages. And please keep an eye on the purple colored bold letters. Those will be the hormonal phenomenon. So as I explained you in simple language, the ovarian and uterine both cycles are going on simultaneously. For teaching purposes or for explanation purposes, we will first deal with ovarian, then uterine, but they are going simultaneously. So in ovarian, you have follicular phase in which you can have the early and late, followed by the ovulation and the luteal phase. They are corresponding in the uterine. Follicular phase is corresponding to proliferative phase, while the luteal is corresponding to secretory. So you can, if you can see the arrow, below the arrow I have written in follicular or proliferative phase, the predominant hormones are FSH, estrogen, LH and small amount of progesterone. So this progesterone I have written as in a small case. In the luteal phase or corresponding secretory phase, the main hormone are progesterone and the small amount of estrogen. So estrogen भाग के कहीं नहीं जा रहा है, estrogen भी है, but it is in less quantity. So the important take home message, not only for hormones but all of us, is harmony is important in life. And जैसे ovarian और uterine दोनों साथ में चलते हैं, हमें multidisciplinary
My shoulder is dislocated literally. It's hurting me very badly. I'm in pain all the time. See this arm, this is as far as I can reach it.
So these mood changes are also again related to the various hormonal changes occurring in the menstrual cycle. Now coming to the, as I said, it is not possible to cover everything in one 25-minute lecture, but I would like to cover many of the things. So first of all, the concept of primordial follicle, which all of us know that it comes when the woman is in the mother's womb only. That time only we have the various follicles. It is nothing but the oocyte and the layer of the granulosa cells. The green ones are the granulosa cells. Okay, so with the primordial, what is more important in the primordial follicle is there is a oocyte which is arrested in डिप्लोटिनी स्टेज ऑफ मियोटिक प्रोफेस. मियोसिस के डिप्लोटिन स्टेज में वो वहां पे रुक गई है oocyte. That is more important. Okay, and very early development of follicles which begins almost 70 days prior. Okay, मतलब इस साइकिल में जो फॉलिकल्स रिक्रूट होने वाले हैं उनका कोहोर्ट, उनका एक ग्रुप है. सो देर आर वेरियस ग्रुप्स विच विल बी परफॉर्मिंग. Of that one group goes to the finale, and of that one group, the one leader or one among that group is going to be the winner of the contest. Okay, तो ये जो हम फिनाले का प्री फिनाले करते हैं कि उसका हम लोग प्रीवियस राउंड लेते हैं, वो राउंड का सिलेक्शन 70 डेज पहले से चालू हो जाता है. एंड व्हाट इज मोर इम्पॉर्टेंट इज ये जो 70 डेज का जो राउंड होता है, इट इज इंडिपेंडेंट ऑफ GnRH. ओके, इसका GnRH से कोई ताल्लुक नहीं है. इट इज इंडिपेंडेंट ऑफ GnRH. इट इज मोस्टली रिलेटेड टू द जक्स्टा पोजिशन. उनका जो पोजिशन है ओवरी में, उससे इट इज मोर रिलेटेड. ओके, and fate of almost all of these follicles is apoptosis. As we know कि millions of follicles होते हैं, उसमें से hardly 400 are utilized in reproductive phase. So most of them become apoptotic. So what is meant by apoptosis? Degenerate हो जाते हैं. We all know the meaning of apoptosis. So what saves them from getting getting degenerated? It is nothing but the FSH. Okay, so we have seen that initial development is independent of gonadotropin, but आगे का जो development है उसके लिए FSH चाहिए. And unless and until the follicle receives the blessings of FSH, the follicle will get apoptosis. So the rescuing of cohort of follicles or savior from the atresia is nothing but the FSH, and we all know these gonadotropins are released in a pulsatile manner. Okay, so this pulsatile manner like FSH and LH, whatever is there in the follicular phase, in the initial phase, is it is usually at 90 minutes. Okay, then next step is recruitment is continuing growth of antral follicles in response to FSH. So what happens once this FSH is secreted from pituitary? So hypothalamus means GnRH gives the signals and the FSH is released, and this FSH acts on granulosa cells which were there in the follicle. So these granulosa cells are now producing estrogen under the influence of FSH. Okay, estrogen is produced by granulosa cells under the influence of FSH. FSH is follicle stimulating hormone. So itself is telling you that it is stimulating the follicles. So what this estrogen does, this estrogen gives negative feedback to FSH, because हमने देखा कि बहुत सारे राउंड में से एक ग्रुप ऑफ कोहोर्ट, एक ग्रुप आया है फिनाले में, तो अभी उसमें से एक को चुनना है, तो अभी कंपटीशन ज्यादा टफ हो गई है, तो बहुत सारे और ग्रुप्स आने लगे, तो देन इट विल बी टफर एंड टफर. सो एस्ट्रोजन क्या करता है, एफएसएच को बोलता है कि बस अभी किसी को मत लाओ, हमारे इसमें ही कंपटीशन रहने दो. ओके, सो इट हैपेंस दैट देयर इज अ नेगेटिव फीडबैक एस्ट्रोजन. This estrogen also causes proliferative changes in endometrium, and it also gives positive feedback for secretion of LH. What is LH? LH is luteinizing hormone. Okay, so this estrogen, if it remains for at the level of more than 200 picogram for more than 48 hours, then there is a positive feedback for LH. What this LH causes, again this LH acts on granulosa cells, and it helps granulosa cells to produce progesterone. This progesterone is again giving feedback to the FSH. So basically it is all interlinked, that FSH is the main hormone which causes the appearance of estrogen. Estrogen causes the appearance of changes in the endometrium, and it gives signals for secretion of LH as well. Okay, and now with the LH there is a secretion of progesterone. So FSH and local estrogen, what they do further stimulate the estrogen. Then this FSH receptor synthesis and expression is enhanced. So estrogen is giving negative feedback for FSH, but it is the same time it is causing more and more number of FSH receptors to appear, so that जितना भी FSH है already वो ज़्यादा काम करेगा. अगर रिसेप्टर नहीं रहेंगे तो वो काम नहीं करेगा. तो FSH को नेगेटिव फीडबैक जा रहा है, बट FSH रिसेप्टर्स आर इन अंडर द पॉजिटिव फीडबैक, and the granulosa cell proliferation and differentiation. So what can be the clinical implication of this? So many of the times what happens, if you see that the endometrial thickness of some patient in the infertility case is less, many of the gynecologists or obstetricians might start estrogen supplementation in the view कि estrogen कम पड़ रहा है, तो मैं estrogen बाहर से सप्लीमेंट करूंगी एक्सोजिनसली, तो उसका एंडोमेट्रियल थिकनेस बढ़ेगा. बट दैट इज अ रॉन्ग कंसेप्ट, क्योंकि एक्सोजिनसली एडमिनिस्टर्ड एस्ट्रोजन rather might give a negative feedback for the FSH, and if there is less amount of FSH than what is required, then it might lead to further decrease in estrogen levels. Further decrease in estrogen level again will hamper the LH secretion, क्योंकि हमने देखा कि छोटे से FSH छोटे से estrogen लेवल पे LH स्टिम्युलेट नहीं हो रहा है, उसका पर्टिकुलर लेवल आने पे ही LH is getting stimulated. Okay, same thing, progesterone given for withdrawal. So almost every 5 to 10% of our gynecopedy is related to the withdrawal, either postponement of menses or because of the amenorrhea. We are writing progesterone. We might write the medroxyprogesterone or any progesterone. So can you tell me for how many time, for how many days we ask the patient to wait if you are giving the progesterone? So once we give the progesterone, once the 5 days course is over, usually the patient gets her menses in 3 to 4 days. But if she doesn't get her menses, we ask her to wait for 15 days, 14 days. Why? Because the exogenous progesterone, जो हम progesterone देते हैं patient को for withdrawal or postponement, whatever, it might stimulate, and this small amount of progesterone might give the feedback for LH and the ovulation. The physiology of ovulation obviously will be covered by the next speaker, but I am just telling you the clinical implication. That's why we ask these patients that we will wait till 14 days, and still if till 14 days if she does not, because after ovulation you all know the luteal phase is constant. So we will wait for 14 days for her menses to occur, and still if she doesn't get, then we will do further investigation. These are the clinical implications of whatever information was there in slide. So we know the concept of two-cell, two-gonadotropin theory. So what are the two gonadotropins? The FSH and the LH. And what are the two cells? The theca and the granulosa cells. So the important point here to notice, theca cells is the outer surrounding in a follicle, and the granulosa cells are the surrounding the oocyte. So these theca cells are vascular, while the granulosa cells are avascular. So whatever the amount, whatever the blood, and through that blood the cholesterol, the substrate they are getting, they are by the diffusion. So unless and until theca cells work properly, even the granulosa cells may not be able to work properly. So what happens? The theca cells receive those under the influence of LH, they will produce androgens, okay, and these androgens will be transferred to granulosa cells, and with the aromatase enzyme, these androgens require both of them, the FSH, the theca cells as well as the granulosa cells, and both gonadotropins FSH and LH, because theca cells are under the LH, while the granulosa cells are under the influence of FSH. So we require both of them to have the good concentration of estrogen. So what can be the clinical implication of this? So especially in hypogonadotropic hypogonadism, we use your FSH because under the influence of granulosa cells will produce more and more estrogen, as well as we use the FSH and LH both in combination for ovulation induction. So it depends on the patient profile. Now till then we have seen how the follicle progresses and what hormones it produces. So the selection of dominant follicle, it purely depends on which type of environment the follicle is able to produce. The follicle which produces the more of estrogen, that means estrogenic environment, and less of androgenic environment, is the winner. Why? Because under the influence of LH, the theca cells produce androgens. These androgens in small amount, as we have seen, they get transferred to granulosa cells. These androgens stimulate estrogens, but if the androgens are more in quantity, then these androgens stimulate androgen production rather than estrogen production. And prematurely elevated LH. The LH is usually absent till mid-cycle. We have seen that LH comes later on after the estrogen comes. Estrogen आता है पहले, FSH आता है, फिर वो estrogen प्रोड्यूस करता है और estrogen पॉजिटिव फीडबैक देता है LH को आने के लिए. तो अगर ये LH पहले से ही आ गया तो this makes it more androgenic, and that's why this premature elevation of LH is one of the reason to alter the FSH-LH ratio, which we have seen more commonly in PCOS patient. And because this premature elevation of LH in PCOS patient, the environment, the microenvironment of a follicle remains androgenic, and that's why there is a difficulty in ovulation. So this FSH-LH ratio is more important to have the further physiology of ovulation. So this is usually the ratio is between 1 to 2. So mostly it is 1:1, and if it gets reversed, so LH अगर बढ़ जाता है तो then there is a problem with ovulation. So the physiology of ovulation will be dealt in later half, so I am not going in details of that. But what we learned till now, as you can see in this hormone profile as well, the important is FSH, which stimulates follicles to produce estrogen. Low levels of estrogen are negative feedback for FSH and LH, and high levels of estrogen are negative feedback for FSH but positive feedback for LH. In this, there is one more hormone, that is activin. The name itself is telling you that activin is activating. So it is basically a facilitatory action for follicle stimulating hormone. The activin is of two types, A and B. You can just remember, first there is B and followed by A. So I am not dealing with the physiology of ovulation. So after ovulation, so we have seen because of FSH and estrogen, there is a LH surge, and this LH surge again gives negative feedback. हमने देखा FSH estrogen ने LH को बुलाया, पर अभी वो LH ने ही negative feedback दिया, उसकी वजह से there is a little bit drop in estrogen, and this drop in estrogen might present to you as mid-menstrual spotting. Because the estrogen level gone a little bit down, there may be mid-menstrual spotting. So now loss of positive stimulation because of drop in the estrogen, there is a loss of positive feedback and there is a negative feedback of progesterone, and because of this there is a shutdown of LH. So we all know that the corpus luteum is receptive to LH. So अगर corpus luteum को maintain करना है तो LH उसको चाहिए ही चाहिए. So what happens to the corpus luteum? First there is a angiogenesis. When there is a LH peak is there is a angiogenesis, and this peak is corresponding to the peak of progesterone and estradiol, which is around 8 to 9 days post ovulation. So why there is a angiogenesis? The same thing, because you want to transport more and more lipids inside for progesterone production. क्योंकि अभी it is a corpus luteum. What is corpus luteum? तो oocyte was there, the LH helped progesterone. So the progesterone production, and this progesterone production again enhances the LH induced luteinization of granulosa cells, and this inhibits the apoptosis. The corpus luteum rapidly declines after 9 to 11 days of ovulation and forms scar-like corpus albicans. So why basically it degenerates? It degenerates because if after 9 to 11 days, if there is no pregnancy, there is no embryo formation, there is no beta HCG production, and this beta HCG production is required for the tissue matrix metalloproteinase to get inhibited. Okay, and tissue inhibitors of matrix inhibitors of metalloproteins to go higher. But if there is no beta HCG, what happens? इनहिबिटर्स नीचे जाते हैं और मैट्रिक्स मेटालोप्रोटीन्स बढ़ते हैं, एंड उसकी वजह से वो डिसइंटीग्रेट हो जाता है. एंड द फाइनल signal for luteinosis, however, is P2 alpha. So along with the hormones, now comes the prostaglandins as well. Okay. This lutein days we can have the margin of 11 to 17 days. So if the patient is having menstrual cycle of 35 days, okay, her luteal phase is fairly going to be of 14 to 15 days. So the follicular phase might change, but the luteal phase is going to be constant, and this we take into consideration in AUB cases as well. We find out what kind of AUB she is having. Is it ovulatory or unovulatory? So almost I will next slide. Okay. So now we have seen now the corpus luteum has become corpus albicans from embryo. So degeneration of corpus luteum causes decrease in estradiol, progesterone inhibin, and plus there is increasing GnRH pulses, क्योंकि हमें पता है ये सब निगेटिव फीडबैक देते हैं. इनका लेवल कम हुआ तो वो फीडबैक जाके वो हाइपोथैलेमस को बताता है कि कम हो गया, कम हो गया, कम हो गया, and GnRH comes in action. So because of this there is a rise in FSH. And with this rise in FSH, there is a new follicular recruitment, which have started preparing 70 days back. Okay. Now only they will decide ki which cohort is going to go ahead and which follicle is becoming dominant follicle is already been selected 70 days back. So what can be the clinical implication of this corpus luteum getting dissolved to corpus albicans and decrease in hormones? So injection HCG, we have seen there are injection HCG is given in many of the patients who come to us with threatened abortion, especially very early in pregnancy. Or even in vitro fertilization cases, they usually start with the injection HCG, even they before there is any event of threatened abortion or PV bleeding. So the purpose of this injection HCG is to stabilize the MMP and inhibit. So this is again negative, this is again all the feedback mechanisms which are working in the ovarian phase. Now coming to the endometrial cycle, remember the first slide where we have seen that the follicular phase is corresponding to proliferate phase, while luteal phase after the ovulation is corresponding to the secrete phase. Now this most important slide. Every one of you please take screenshot or get it registered in your brain, because if you understand this, your AUB part is very well handled. Okay. So ovulation part mainly we are more concerned when it is infertility. But what the menstruation is the visible component. So maximum patients we are having related to the menstrual normality than infertility. So understanding the visible symptomatic presentation of menstrual cycle is important. So estrogen is like a bricks, and the progesterone is like a cement. So just imagine a wall being built where there is सकती है कि वहां पे ब्रिक्स ही नहीं है, सिर्फ सीमेंट डाला है, सीमेंट डाला है, सीमेंट डाला है. आई डोंट थिंक कि वॉल खड़ी रहेगी. सो व्हाट दैट मीन दैट इस्ट्रोजन प्राइम होगा एंडोमेट्रियम तो ही प्रोजेस्ट्रॉन एक्ट करेगा. एंड दैट इज द बेसिस फॉर मेनी ऑफ द थिंग्स लाइक अमेनोरिया जिसमें तुम विड्रॉल देते हो. सेम थिंग estrogen progesterone मतलब what kind of histopath report you get after doing suppose D&C or after doing hysteroscopy, you send it for histopathological examination, what kind of report you get. So depending on the report, with this concept you can go ahead. So estrogen is like a bricks, progesterone is like a cement. So even if only bricks are there and there is no progesterone, the wall will stand. The wall will stand, but the wall will not be stable. Okay, that's why with the estrogen you get so many days amenorrhea. प्रोजेस्ट्रॉन नहीं है, जैसे ओव्यूलेशन नहीं हो रहा है पीसीओएस में, बट एस्ट्रोजन इज देयर, सो वॉल इज बीइंग बिल्ट, but it is not stable, and again they break out with the menorrhagia or they have delayed menses. Okay, so please remember throughout that estrogen is bricks, progesterone is cement. Now in the uterine, before going to the uterine cycle, first understand the decidua functionalis and basalis. So the decidua functionalis is the main of the zone of the endometrium, is almost 2/3, and this is the zone which is 1/3, and it is the source of मैं उसको कल टीसीआरई के लिए ऐसे आप कर रहे हो तो डेफिनेटली इट इज गोइंग टू फेल. सो फर्स्ट अंडरस्टैंड दैट इन टीसीआरई वी वांट टू गो टू बेसल लेयर सो दैट उसको वापस भी नहीं होगा. सो दिस इज द क्लिनिकल implication that you can post the pills for 3 months and then post her for TCRI. Same thing is uterine artery goes as radial artery, again divides into basal and spiral. The basal artery supports the basal layer of endometrium, which is a regenerative, and it is not responding to hormone, while the spiral artery supports the decidua functionalis, and the important is it has no anastomosis. Spiral arteries do not anastomize. That's why ischemia, which occurs during the breakdown, that is during the menstrual phase, is profound because they don't have anastomosis in them. Okay? Now coming to proliferative phase.
Sorry to interrupt
the
you,
first
ma'am.
day, you all know when the bleeding starts, it is called as first day. Yeah, I will be hardly three more slides.
Okay, ma'am.
Should I continue?
Okay, ma'am.
Okay, so with the in the proliferative phase, now we have seen the estrogen has already started and of the endometrium, and this as well as the glands will be regenerated, and there will be the connection, there will be link between the glandular epithelium lining, and there will be continuous layer formation under the influence of estrogen. So there is one gland, other gland, and now they handhold each other, and there is a formation of continuous layer, and that is the basis when there is an uncontrolled marriage which is not responding progesterone. We might injectable estrogen to these patients. So these are the various material. So under the secretory formation of subnuclear vacuoles and then strong receptor the drug progesterone inhibits oncogene expression of estrogen. If there is no secretory phase or there is inadequate progesterone, the estrogen will have a positive effect.
Hello, Shreya.
Okay.
Yeah.
So after the withdrawal of sex steroids, there is a profound spiral artery vascular spasm, as well as there is endometrial ischemia, and again, as we have seen the metalloprotein, same thing, breakdown of lysosomes and proteolytic enzymes is there, which are stabilized by progesterone. Progesterone is not allowing the breakdown of these lysosomes. Once the progesterone level is gone down, then there will be breakdown and there will be the endometrial shedding. But to have this blood getting drained out from cervix, there are myometrial contractions required, and that is the basis of primary dysmenorrhea. So this picture depicts the various hormonal changes and the ovarian and endometrial cycle. So I hope it give you some of the insights for the physiology of menstruation. If you have any queries, you can ask in chat box. We for patient hearing, as well as the team ICOG, especially the Vaishali Kodenaik ma'am, for giving me opportunity to talk on this topic of physiology of menstruation. Thank you so much.
Thank you, Dr. Shilpa. We will now proceed to the next talk by Dr. Meeta Gupta. Madam is a teacher for the
Manasi, there is a question. If we can just ask that, there's only one question. Which IV estrogen is available and dose frequency, Shilpa?
So please repeat the question. Is it the
Which IV estrogen is available and what is the dose frequency of that?
Yes, so what we call it as equine estrogen preparations are available, and there may be many. What I know, the brand name is of injection Aquaveron, which is available in the injectable form. And if the patient is not responding to progesterone, the first line of treatment for any kind of menorrhagia is always progesterone. If the patient is not responding or there is a severe menorrhagia, then only we go ahead for the injectable estrogen.
Absolutely. There's hardly any time when we actually need to use this IV estrogen. Okay, over to you, Mansi.
Okay, thank you, sir. I now welcome Dr. Meeta Gupta. Madam is a teacher for the last 20 years. She is the Dean Academics and the Professor and Head of the Department of OBGY in AIMS Vijaypur, Jammu. She is a winner of Women's Health Researcher Award in the senior category. And she has many publications to her credit. I welcome you, madam, and hand over to you for the next talk.
Thank you so much, Mansi. Can I share my screen till I am giving my vote?
Yes, ma'am.
Yes.
Please.
Thank you
At the
so
end
much.
of both the talks, Manasi, let's ask our chairpersons also to give their inputs on both the topics.
Yes.
So I hope my slides are visible.
Absolutely,
Yes.
Dr. Meeta.
Thank you so much,
Yes.
sir. At the onset, I would like to thank Parag Biniwala, sir, and Sarita Balarao, ma'am, and especially Vaishali, ma'am, for giving me this platform of ICOG, and Chaitanya, sir, for giving us this on behalf of Endocrinology Committee to be presenting over here. Greetings from the north part of India, that is Jammu. I'm presently from AIMS Jammu, and Dr. Shipra has already made my journey easy because Dr. Shilpa has talked very nicely of physiology of menstruation, and I will be continuing with physiology of ovulation. So this is what we are supposed to look into, where the ovarian cycle and then the uterine cycle, and they all will be part of the menstrual cycle. This is where the journey of the follicle will start from growth, then youth, finally to old age, and then death, that is atresia. So if you look at if you just look at the entire ovarian cycle, we have to understand that a fully developed and functioning hypothalamic pituitary ovarian axis is foremost for ovulation to occur. And it is a critical part of a female reproductive cycle because it leads to the release of ovum and ultimately pregnancy in the reproductive age group. So hypothalamic, pituitary, and ovarian steroid hormones are responsible for this HPO axis. If you look at the embryological growth pattern, the ovarian cells, that is the primordial germ cells, they give rise to the oogonia. The coelomic epithelium will give rise to the granular cells, and the ovarian stroma is formed from the mesenchymal gonadal ridge. With development of time, it is said that in the intrauterine life, by week 3, the primordial germ cells will appear in the yolk sac. They will migrate to gonadal ridge from the primary sex cord cells by week 6, and by 10 to 11 weeks intrauterine, the ovaries and testes can be distinct histologically. So the peak oocytes will be present at about 20 weeks intrauterine, and the number is maximum, that is 6 to 7 million. After this, there starts atresia, and at the time of birth, the number of oocytes are only left to 1 to 2 million. At puberty, the atresia continues, and at puberty, the number comes down to about 3 lakhs, and only 400 to 500 ovulate during the reproductive lifespan of an average female. When menopause occurs, the entire ovaries will turn into a fibrous tissue. So what is that a hypothalamic pituitary ovarian axis? How does that govern the entire follicle maturation and ovulation? We know that the GnRH are released in a pulsatile form from the hypothalamus, which gives a positive feedback on the anterior pituitary and leads to the release of FSH and LH. Finally, the FSH and LH, this result in follicular maturation, ovulation, and the production of the sex steroid hormones. So it is the rising serum levels of these hormones and inhibin, which is produced from the ovary, which will then produce a negative feedback on the GnRH and the gonadotropin release. So the GnRH is a decapeptide, and it is formed and released by the paraventricular nucleus of the hypothalamus, which acts on the anterior pituitary and leads to the stimulation and release of FSH and LH. The neurons which release the GnRH, they are from the olfactory placodes. Any defect in this neuronal migration will lead to decrease in level of LH hormones, which will lead to anovulation. Decrease in level of FSH, that will cause no folliculogenesis. If the level of estrogens decrease, then it leads to delayed puberty. And if the levels of progesterones are hampered, then it causes primary amenorrhea. So we have realized that it is the GnRH pulsity release that is important. But what is this GnRH pulse that we are talking of? A pulse refers to the burst of GnRH secretion that occurs from the hypothalamus pituitary portal circulation, and it occurs at regular intervals of about 30 to 120 minutes. Frequency and amplitude, and why they are important is that in the early follicular phase, the frequency of these pulses are low. This corresponds to more FSH production and ultimately follicular recruitment. Whereas in the late follicular phase, in the pre-ovulatory, there starts the high frequency pulses, which leads to more LH formation, and this leads to LH surge, finally leading to ovulation. Whereas then the luteal phase once comes, these pulses frequency decrease. So a low and high GnRH pulse means one pulse every 120 minutes, that is slow. This causes preferential FSH secretion, and this leads to follicular development. Whereas a high frequency pulse, that is approximately one pulse every 30 to 60 minutes, this leads to LH secretion and leads to LH surge and ovulation in the mid-cycle. So this low pulses will correspond to FSH stimulation, and these high pulses will correspond to LH secretions. Coming to FSH and LH, both are glycoprotein hormones which are secreted from the anterior pituitary, and they are also pulsatile manner. But what we have to understand that both LH and FSH have a common alpha subunit, but a unique beta subunit, which is responsible for the receptor binding proteins and the function of the hormone. The FSH receptors are present on the granulosa cells, whereas the LH receptors are present on the theca cells, and they will produce testosterone, which will be a precursor for estrogen synthesis in the granulosa cells. Whereas the LH receptors present on the granulosa cells, they will be in the late follicular phase and the corpus luteum. They are usually expressed by the presence of FSH and rising estrogen levels. This LH receptor action causes increased LH stimulation, which ultimately causes ovulation, luteinization or formation of the corpus luteum, and progesterone production. So the LH would be mainly responsible for the ovulation and will also be responsible for maintenance of the corpus luteum in a non-pregnant female, whereas the FSH we know is important for the selection of cohort of follicles every month, for the growth of follicles, selection of the dominant follicle, and the LH surge to occur before ovulation. So ultimately, this FSH is also responsible for the collagen breakdown, which is required for the ovulation to occur. So if we look at the steroidogenesis, we have to understand that the levels of LH and FSH vary with different ages. Ovary will produce estrogens by 8 weeks of intragestation life, but its levels will fall at birth. FSH and LH ratios are high in premenarcheal as well as postmenopausal women. And in puberty, the FSH-LH ratio is about 2:1 in the initial phase of the menstrual cycle. The increased estrogen production, this leads to thelarchy and height growth spurt. The greater adrenal androgen production will lead to pubarchy. The ovulation will lead to menarche, and after menopause, this all will be changed because the peripheral conversion of androstenone to estrone will be occurring. So coming to the steroid hormones, that is estrogen and progesterone, they have intracellular receptors, The naturally occurring estrogen is in 3 forms. Most common occurring estrogen in the reproductive is E2, which is commonly known as estradiol. In postmenopausal females, it is E1, which is known as estrone. Most specific for pregnancy is E3, that is estriol. And most common estrogen in pregnancy is estradiol. So what you have to understand that most common in pregnancy is estradiol, E2, but most specific for pregnancy is E3 levels, that is known as estriol. Adrenal glands and peripheral tissues produce androgens which lead to estrogen formation. In obese PCOS females, that is why this increased androgens will get converted to estrogen in peripheral tissues, and this ratio may also get reversed. So just to reiterate that the estrogen is available in 3, E1, E2, and E3. E2 is most common. This is known as estradiol. This is biologically active and it is produced from the ovarian estrogen. E1 is the estrone, which is very weakly active and small amounts are produced from ovary. This is usually seen in your postmenopausal females. E3, which was most specific for pregnancy, is known as estradiol. It does not have any biological activity. It is in pregnancy, it is synthesized by the placenta, and it is the major estrogen of the placenta. These are the ranges I have just put in for reference, which everybody has to learn. Coming to the menstrual cycle, we have to understand that the cycle is from day 1 to day 5, which corresponds to the early follicular phase of the ovary, the menstrual phase of the endometrium, and both the estrogen and progesterone levels are very low. In the 6th to 14th day, that is the pre-ovulation phase, this responds to the late follicular stage of the ovarian phase. The endometrium would correspond to the proliferative phase, and your estrogen will be responsible for this proliferation. Coming to the last phase or the luteal phase, that is cycle 15 to 28 of an average female. This is known as the luteal ovarian phase. It is on the endometrium, it will appear as a secretory change, and this is all because of the presence of the progesterone. So this is what I want each of the PGs to understand, because this is first is the oogenesis and the second is the follicular development. If you look at the oogenesis side, we have the fetal period in which during the intrauterine life, the oogonia are present. They undergo mitosis and it causes primary oocyte development. This primary oocyte will get arrested in the phase of prophase of meiosis 1. This, if you look into the adult phase, that is the follicular development, these primary oocytes will also be known as the primordial follicle. As the girl is there till she attains childhood, all the oogonia would be in this phase only, that is the primary oocyte. Then once the reproductive years starts and the HPO axis is fully functional, this primary oocyte, which is in the prophase stage, will undergo a selected oocyte and it will complete its meiosis first. Once it completes its meiosis first, it will go into the secondary oocyte where the secondary meiosis will begin, and these secondary oocytes will be arrested in metaphase, and also the first polar body will be formed. Once this secondary oocyte undergoes ovulation, then the sperm may be available and the fertilization will be possible. And just before this, the meiosis will be complete, followed by the release of secondary polar body and the zygote once the oocyte is fertilized with the sperm. This is what is known as the oogenesis complete. But if you look into the terms of the follicular development, the primary oocyte is known as the primary follicle. Once the primary follicle, under the influence of various hormones, will grow in size and mature into the secondary follicle, which will further undergo changes and turn into the tertiary or the Graafian follicle. And once this Graafian follicle undergoes the hormonal changes, it will rupture, lead to the release of the oocyte. if we can understand this cycle, then entire physiology of ovulation will be crystal clear to each and every one of us. So this is what is oogenesis. During fetal life, the oogonia in the fetal ovary will undergo mitosis, will lead to primary oocyte formation, and then after achieving puberty, these primary oocytes, which are arrested in prophase of meiosis 1, this will undergo completion with the release of first polar body and secondary oocyte. Once this secondary oocyte is formed, then the meiosis 2 begins, which is arrested in the phase of metaphase of meiosis 2. And the minute they are released, ovulation will occur and the second polar body would be released, and fertilization, if occurs, would lead to zygote formation. This is what is entirely is that I will just again repeat that in the fetal period, the primordial germ cells differentiate into oogonia and they undergo mitosis and convert into primary oocytes where the meiosis begins. This is arrested till ovulation. Then a primary oocyte with all its surrounding epithelials will be known as the primordial follicle. And in the childhood, these primary oocytes are always suspended in the prophase 1 of meiosis. And during the puberty, as the pubertal changes occur, these primordial follicles will mature each month into the primary follicles, which may grow into secondary follicle, tertiary, and finally ovulation to occur. We understood that first, it is the meiosis where there is arrest of prophase from the primary follicle, from the primary follicle to the primordial follicle to the primary follicle, where all these cells are in the meiosis, stage 1 of prophase. Likewise, but what is this that causes the mechanism of arrest for oocyte growth? This is the oocyte maturation inhibitor, that is OMI, which are secreted from the granular cells, as well as high levels of CAMP, which inhibit meiosis, as well as there is a communication via connexin gaps. This causes all the meiosis to arrest. The meiosis will be reassumption of these meiosis will occur once there is the LH surge in the mid-cycle, as well as the gap junctions that was present, they get disrupted. This caused to decrease in CMP levels. As a result, this meiosis, which was arrested in the secondary oocyte or in the primary oocyte, will lead to formation or the growth of the further of the follicle. So coming to folliculogenesis phase, we have understood that one surviving mature follicle will be destined to ovulate if it undergoes the primordial follicle or primary follicle, then the pre-antral follicle or the secondary follicle, antral or the tertiary follicle, and finally the pre-ovulatory follicle will be formed. So primordial follicle would be once the cells have a single layer of granulosa layer. They will be known as a primary follicle if this granular cells start proliferating. Then finally, the secondary follicle will be formed in which the theca cells will appear. And finally, the tertiary follicle or the antral stage where the mature follicle will be formed and it is ready for ovulation. So this is the primordial follicle, which is the most primitive form of the ovarian follicle. They are present in ovary from birth. They consist of the immature egg, that is the oocyte, which is surrounded by a single layer of flattened cell, that is the granulosa cells. And the majority of the follicles in the ovary are in this primordial stage. Then they increase in size. The granulosa cells become cuboidal, as well as there occurs multiplication of these cuboidal cells. And there occurs a development of gap junctions between the granulosa and the oocytes. And this primordial follicle is now the primary follicle. This primary follicle will now further increase in size. There will occur the theca as well as the granulosa cells. These theca cells, which will be the hormone-producing cells, will begin to develop outside the follicles, whereas the granulosa cells will proliferate further to form the multiple layers around the oocyte. Finally, the secondary follicle is formed. Then comes the Graafian follicle, because the specific receptors of FSH will develop on the granulosa cells, which will initiate the steroid hormone synthesis, as well as stimulate the granulosa cells to proliferate and further grow. Specific LH receptors will develop on the theca cells, as well as the theca interna and theca externa differentiation will be there. This will develop estrogen. This will develop, and finally estrogen would become the dominant substance in follicular fluid around the ovarian steroidogenesis. So what we have to understand that a follicular development growth is in two phases. First is the early phase and the late phase. The early phase is gonadotropin independent recruitment. This phase would begin with the primordial follicle recruitment from the resting pool and will reach till the follicle reaches the early antral size, that is 2 to 5 millimeter in diameter. It is governed on the local growth factors, that is oocyte controlled, or other factors like growth differentiating factor and bone morphogenic protein. The late phase, that is FSH control, is the selection window in which the cohort which having large antral follicles will select one to become the dominant or the mature follicle, and the follicles will be reaching this stage will depend upon the estrogen level. So finally, coming to the two-cell or the two-gonadotropin therapy, it says that the ovarian estrogen biosynthesis requires the action of both LH and FSH on theca and granulosa cells. As we all know that the pre-antral or the antral follicles, the LH receptor is limited on the theca cells, whereas the FSH receptor would be on the granulosa cells. If you look at the two-gonadotropin therapy, which is one of the questions usually coming in our postgraduate examination, you have to understand that the LH receptors, which are present on the theca cells, once they combine with LH, they lead to CAMP activation, and this CAMP will lead to cytokine CYP or 1117 activation, these enzymes, which will lead to androstenone formation from cholesterol, and this androstenone would be the precursor for your estrogen in the granulosa cell, which would be occurring only once the FSH occurs. So in PCOS, what happens is this androgen will not be converted into the estrogen. As a result, your male hormones or the androstenones would be increased and as compared to the estrogen precursors. So what you have to understand that these androstenedione diffuses across the basement membrane of the theca cells to enter the granulosa cells of the ovary, and under the influence of FSH on the granulosa cells, these androstenediones is converted by an enzyme aromatase to estrone and estradiol. So why it is important to know about this two-cell two-gonadotropin theory is that FSH is required for early folliculogenesis, but final stage of maturation requires both LH and FSH. Increasing amount of androgen substrate for estrogen production is required as it promotes the growth of dominant follicles as well as hastens the regression of smaller follicles. So expression of FSH receptor on granulosa cells is important, and cytochrome 450 aromatase induced conversion of androstenone to estradiol is responsible for the conversion into the active estradiol form. And most FSH receptive responsive follicles start estradiol production, hence the LH receptors will appear. So if you look at the ovulatory phase, we have understood that the follicular stage is there, which would be variable from 10 to 14 days. But the second phase, that is the luteal phase, is usually fixed to about 14 in any average female. The follicular phase will have the high FSH would be responsible for recruitment of the follicles. Then during mid-follicular phase, these follicles will produce greater amounts of estrogen and inhibin. This will lead to decline in FSH, leading to the negative feedback, And this negative feedback will cause a drop in FSH level, which will help in other follicles to decrease, will not grow, but only will select the dominant follicle to further grow in size. So the granulosa cells present
Sorry to
will
interrupt you, ma'am.
Yes, ma'am, it is finished. Just 2 slides more and it is finished.
Okay, ma'am.
So ovulation is, you have to understand that LH surge was about 48 hours before ovulation, and this LH surge is usually preceded by a sustained high levels of E2, that is more than 200 picogram per ml for 50 hours for this LH surge to occur. I will be leaving this. So once the luteal phase is there, post-ovulation, the follicular cells will convert, that is the corpus luteum. They require LH, and this LH stimulation will lead to progesterone dominance. If you want to look for ovulation or you want to confirm, usually a progesterone levels can be done on day 21. And if the progesterone levels are more than 3 nanogram per ml, this is a documentation that ovulation has occurred. If pregnancy does not occur, this luteolysis, that corpus luteum, leads to corpus albicans, or that is known as the white body. This leads to decreased estrogen and progesterone, and ultimately this will lead to increased FSH, and finally a new follicular recruitment cycle will start. These are the endometrial changes that has already been taken from my previous speaker. Please remember this, where we have to correlate the gonadotropins, the estradiols with the growth of follicle and the endometrial cycle. Thank you.
Excellent presentation, Dr. Meeta. We were expecting the details and you have really covered it so well. Shilpa has covered the physiology of menstruation and you have really given us a good insight into ovulation and the changes. So thank you so much. We have professors and academicians as our chairpersons, and I request Dr. Shelly ma'am, your views on first talk first. Your inputs.
So much, Dr. Vaishali. At the outset, I would like to thank Dr. Parag and Dr. Sarita ma'am for having me in this series.
Shelly ma'am, you're little. Shelly ma'am, can you be little louder?
Am I audible?
Yes, you are.
Okay. So I must congratulate Dr. Chaitanya also for initiating this web series for our PGs, because these chapters, the physiology and the anatomy part, our PG escapes. They jump to the clinical part more often. So I insist them to read these chapters first thoroughly, then you will be able to build your blocks. So these are the building blocks for our option gynae. And I must congratulate Dr. Shilpa for excellent oration, and you have very well covered this complex topic and you have made it simplified. And the interesting points, you have correlate the physiology with the clinical scenarios like amenorrhea, like infertility and AOB. So I must congratulate you. And Dr. Meeta, my good friend, a wonderful orator.
Thank you.
You have covered the topic so well, so well. So congratulations to both of you. And all the PGs who are with us, I would like to emphasize again and again, please go through these chapters thoroughly so that you can understand the physiology of the patient and you can use this knowledge in treating these patients. Thank you so much. Thank you, sir, for having me. Parag sir, thank you.
Thank you, Meeta ma'am. We request another chairperson, very well learned madam. Madam, are you there? We would like to hear from you.
At the outset, I should congratulate the entire team, the ICOG and FOGSI Endocrine Committee, Saitana and Mansi, and wonderful deliberation by both the speakers. The basis, we have to be strong. As Shaili mentioned about it, we always insist the basic should be sound, so that they can, when they practice, they can apply that. And the first speaker insists on the 2 cells and the 2 gonadotropin. The second speaker also did the thing. Though actually, this, though it is basic, it is little complicated. It's a complex. And they require hypothalamo-pituitary axis, the intact, and both of them talked about the clinical aspect of it. That is wonderful. And Meeta was talking about the various hormones, how menarche, thalarche, pubarche, which is very important. And very nicely pointed out the salient point, the difference between oogenesis and folliculogenesis. She pointed out that will help in induction of ovulation and other things. It's really, I should congratulate Parag and the entire ICOG and endocrine FOGSI team for this thought about doing it right from basic. It's really honored to be a part of this program. Thank you so much. I learned a little bit. It was refreshing to us, no? Okay. Thank you.
Thank you,
Yes,
madam.
Yes, Chaitanya.
Vaishali, Dr. Parag has joined.
Yes, Chaitanya.
Yeah,
Did you say?
Dr. Parag has joined.
Parag sir has joined.
I'll just take 2 minutes and address the audience. Good evening. I bring greetings from ICOG, and it's indeed a pleasure to be sitting here and relearning very basic topics of gynecology. I must appreciate the efforts put in by the endocrine committee of FOGSI, led by Dr. Chaitanya Gadpule, ably assisted by Professor Vaishali Korde-Nayak and the 4 coordinators, Manasi Naralkar, Manasi Sharma, Madhu Juneja, and Vinuta. About 3 months ago, when Chaitanya and Vaishali approached me because they wanted to start this particular series, I jumped at this opportunity because endocrinology is something which has to be learned right from basics. So Chaitanya, thank you for getting this particular module to ICOG, and the only suggestion would be we should have it every month, because there's so much to learn, and I heard Shilpa's lecture partially and Meeta's lecture fully. Both of you have done exceedingly well, and thank you, Dr. Hepzibah, thank you, Shaili, for joining here. Basically, we are looking at senior professors like you to be on this platform, because this is going to be a good learning experience for all of us, not only the youngsters and postgraduates, though we are aiming at more and more postgraduates to join in. With Shaili, you and even Meeta, you all can help us in disseminating information about hormony. But it is definitely a good learning experience for senior people as well. So thank you, Chaitanya, Vaishali, and the entire team for a wonderful job. Thank you.
Thank you,
Sir, both of us are thankful to you for giving us an opportunity to conduct this program under the aegis of ICOG. Vaishali has carved out the program very nicely, and we are going to have it every month, third Wednesday of every month, 4 to 5:30, and we have already put down the topics for the next almost 2 years. And so we are hoping that we should be able to continue the program even after your tenure, the next tenure.
Absolutely. I'm sure Sheila Mane will also continue this activity very happily.
Thank you, sir. Over to you, Mane.
Second that, what Chaitanya had said. So thank you so much for always supporting us in all academic things which appear boring, but for the students and for everyone, they are very important. You always support us for this, and this time a national platform you have offered. Thank you so much.
Not boring at all. It's a good learning experience. When Meeta was speaking, I was just trying to concentrate. So, okay, this is the basic, and we don't even think about it. We just talk in the air, probably.
Yes, absolutely, sir. Both the speakers, they have given us the clinical importance of all these things. What Shilpa was giving, all those tips, the purple color things, and those are very important. And Dr. Meeta also, she summarized it. I was thinking, we were discussing 25 minutes will be more, 30 minutes will be more, but they have fully utilized it, and they just went on. So I think it's a big boost to this program. So thank you so much, both the speakers.
So they are very nice. beautifully
20 minutes.
amalgamated the theoretical
Thank you.
topic into clinical application. Yes, over to you, Manas.
Thank you. So now I'll hand over to Dr. Vinutha to conduct the quiz.
Good evening, all. Thank you, Parag sir, Vaishali ma'am, and Chaitanya sir. So, going back to my PG days, I really studied hard. So, I took Spiroff and started with the physiology of ovulation and menstruation. And to be too frank, I took 1 week to read because that two cell two gonadotropin theory, like, how many ever times you read, it was still confusing. We had to go back and read. And thank you, Shilpa ma'am and Meeta ma'am. It was an excellent talk. Like, you covered everything in this just 1 hour. This is all we need to know, and this is all we need to write in exams. So the quiz time is allotted for 15 minutes. The first 10 minutes, I will take you through the questions, and then the rest 5 minutes, we can discuss the key.
Yeah, they can write the answers in the chat box.
So is my screen visible?
Yes.
Yes. So you can start answering in the chat box. So the time is 5:27 now, and this will go on till 5:37, and then we will take the answers.
You can read out the questions as well, Vinutha.
Shall I, sir? Okay.
Yes.
Yeah, even I think reading the questions.
Yes, I'll do that. Okay.
Thank you.
Which hormone surge is primarily responsible for triggering ovulation? So as I read, you can start answering. We are expecting more people to participate. Be active. So the next question, what is the main site of estradiol production during the follicular phase? Okay. So which of the following changes occurs just before ovulation? The questions are very easy and simple, and most of all of the questions are covered by our speakers. So it should not take too much time for you to answer these questions. Thank you. The LH surge causes all of the following except next question. What is the dominant follicle called post-ovulation? Okay. During the menstrual cycle of 28 days, ovulation typically occurs during which day? We'll move on. Which factor is essential for follicle rupture during ovulation? The next question, which enzyme facilitates breakdown of follicular wall during ovulation? Excellent. What happens to the oocyte at the time of ovulation? What happens to the oocyte at the time of ovulation? Okay. Which of the following initiates the LH surge? Next one. Which layer of the endometrium is shed during menstruation? Which hormone withdrawal triggers menstruation? Thirteenth question. What is the average volume of blood loss during normal menstruation? Next one. Which substance is responsible for uterine contractions during menstruation? Okay. 15th. Which endometrial phase is progesterone dominant? Okay. Which cytokine plays a role in endometrial breakdown during menstruation? Which cells regenerate the endometrial lining after menstruation? How long does the average menstrual period last? The proliferative phase of the endometrial cycle is driven primarily by which hormone? Okay. The last question. Which endometrial change is seen in the late secretory phase? Thank you very much for all your responses. Now we shall move to the keys. Okay. My screen is visible?
Yes, ma'am.
Yes, Vinuta.
Okay. So which hormone surge is primarily responsible for ovulation trigger? All of you gave the right answer. It is B, LH. And then main site of estradiol production in the follicular phase is granulosa cells. And which of the following changes occurs just before ovulation is surge in LH? And the LH surge causes all of the following except inhibition of theca cell functions. Then the dominant follicle post-ovulation is called as corpus luteum. And in an average 28-day cycle, ovulation typically occurs 14th day. And which factor is essential for follicular rupture during ovulation is prostaglandins. And enzyme responsible for breakdown during ovulation is collagenase. And what happens to the oocyte at the time of ovulation? There is arrest in metaphase 2. Which of the following initiates the LH surge? It is positive feedback of high estrogen. And which layer of endometrium is shed during menstruation? It is the functionalis. Which hormone withdrawal triggers menstruation? We all know it, progesterone. What is the average amount of blood loss during menstrual cycle? Actually, most of you gave answer as D, but if you see the FIGO guidelines, it says the average is 20 to 80 ml. So anything more than 80 ml is menorrhagia. So I take this like as less than 80 and consider your answer as correct. Which substance is responsible for uterine contractions during menstruation is prostaglandins. Which endometrial phase is progesterone dominant? It is the luteal or the secretory phase. Which cytokine plays a role in endometrial breakdown during menstruation is TNF alpha. Many of you gave answer as vascular endothelial growth factor, but it is TNF alpha. Which cell regenerates the endometrial lining after menstruation? It is the endometrial glandular cells from the basalis. So how long does the average menstrual period last? Most of you gave it as 5 days. And FIGO also says it as 4 to 8 days. The proliferative phase of the endometrial cycle is driven primarily by estrogen. And the last question, which endometrial changes is seen in the late secretory phase? It is the spiral artery constrictions. Thank you very much.
Thank you, Dr. Vinuta. I would now request Dr. Vaishali Korde Nayak to propose the vote of thanks.
Before Vaishali proposes the vote of thanks, I would like to congratulate Vinuta. That was a wonderful quiz conducted, nice questions, and the way you have answered them with the references and all, I am impressed. Thank you so much for that.
Thank you for giving this opportunity, sir.
Yes, Chaitanya, I agree with you. She got those references, and as a teacher, I was so happy when I saw the references for the keys. So very well done, dear Dr. Vinuta. It was very nicely conducted quiz. And we come to the end of this first session of this series, and I would like to propose a vote of thanks. We would like to thank our FOGSI President, Dr. Sunita Tandurkar Madam, for giving us this opportunity. We are really grateful to ICOG Chairperson Dr. Parag Biniwale, who has accepted this and who has always supported us, and especially for this program. Dr. Chaitanya Ganpule, who is the key person behind this series, who's sitting chairperson of Endocrinology Committee. We can't thank you enough. You are party to this. So, but the efforts and
no thanks for the host, please.
Yes, you are the host, but thank you for this encouragement, and very well, whatever I sent you, you accepted the whole program, and I would be always grateful for that. Thank you, Dr. Chaitanya. We would also like to thank Sarita Bhalerao Madam, the Secretary of ICOG. We are grateful to our today's speakers, the chairpersons, and their inputs, and the young team of our coordinators, Mansi Naralkar, Dr. Mansi, the other Mansi, then Dr. Madhu and Dr. Vinutha. Vinutha, welcome to the team. We are very happy to have you. And I would also like to thank ICOG team, Nilima especially, for such a prompt work she always does, and all the IT support provided today. So thank you. And this was the first first session of this series. So I request now spread a word, and Nilima also send it to all the ICOG members, FICOG members. Last week I attended the internal iliac ligation session, and more than 500 delegates were there. The other people couldn't join. So I just wish that this program also get the same kind of a response, and we will be there. We will bring you the next session, and we will also try to see that this particular episode gets uploaded on the ICOG website. We will take Parag sir's help and Dr. Chaitanya's help for doing that. And you please inform your postgraduate students to join in more number next time. Thank you so much. Take care.
Thank you, Vaishali, and thank you one and all. Have a very good evening.
Thank you.